Hello and welcome everyone to our first in the series of the Healthcare Associated Infection Reduction Summits. I'm Lori Murray Snyder from Acumentra Health, Health Insights Oregon affiliate located in Portland. Joining me are Health Insights staff from Nevada, New Mexico, and Utah. Today we also welcome presenters representing the 4 states. With a wide range of experience on the topics listed in the agenda. You can read more about each speaker in the speaker bios handout. I wanted to let you know that this presentation is being recorded. And also, if you are attending this presentation and have not yet registered, if you would please enter your name, state, and organization in the chat, please, so we can record that. Thank you. Next slide, please. Okay, so let's review the materials for today's session. All registered attendees should have received an agenda, the speaker bios, a set of the slide handouts, and a blank action plan to record your ahas, future actions, and takeaways. If you did not receive those, you can find these items in the file section on your screen, and there's a drop down, so it'll scroll. Lisa, could you go over to the files and just scroll? So these materials are here for you, and you can download these materials as you need them. So our request of you for this event, we would like you to be present, to participate in the chat and over the phone during the question and answer section. We would like you to also participate in the polling questions that will come up in the presentations. And lastly, we would greatly appreciate it if you would complete the evaluation at the end of the presentation. An evaluation link will be available on your screen and will also be provided in a follow-up email. Thinking about action. We would like you all to be thinking about action today. Has an idea for change entered your mind? What have you learned from the speakers or something you saw in the chat? What made you say, What one thing will you do differently? How will you share what you have learned with others? Go ahead and jot some of these things down in your action plan form or chat them in as you think of them. We'll all learn from each other during this presentation. Here's a copy of the action form so you can see what it looks like. This form is, you can print it out and write in it, or it is a fillable form, so you can do it electronically as well. So now it's time to reach out. Let's test our chat function. So in the chat, please let us know what state you're from and how many people are watching with you. You can do that now, please. Great. Looks like we have a lot of great participants here from all over. Next, let's check out our polling function. So please answer the question, when was the last time you took a vacation, a week's vacation? The polling's up now. Looks like a lot of you need a vacation. Okay. Today we are pleased to have presenters representing the 4 Health Insights states, each with a wide range of experience on CDI and antimicrobial stewardship. From Nevada, we welcome Rochelle Nielsen. Rochelle is an infection preventionist from St. Mary's Regional Medical Center in Reno. Next, from Oregon, we have Dr. Genevieve Buser. Dr. Buser is a public health physician who works at the Oregon Public Health Division in Portland. From Utah, we are pleased to welcome Dr. Whitney Buckle. Dr. Buckle is an infectious diseases clinical pharmacist with Intermountain Medical Center located in Murray. And from New Mexico, Dr. Susan Kelly is a professor of internal medicine and infectious diseases at the University of New Mexico and the VA healthcare system. So now I'd like to turn the presentation over to Rochelle.
Good morning, everyone. I'm so pleased to be able to have the opportunity to talk to you today and to share some experiences that we have had here at St. Mary's Regional Medical Center in Reno. In setting up for this presentation, we ran into some IP challenges. So I want to thank Lisa and Lori for advancing my slides for me today, since I don't have that capability here on my computer right now. So please bear with me as we deal with these challenges as we're trying to walk through this presentation. Thank you so much for the introduction. I wanted to acknowledge at this time as well Dr. Elaine Yee, who's our Infection Prevention Medical Director. She's an infectious disease expert here in Reno, Nevada, and she has been a stalwart supporter of all of our programs for many years, and she continues to provide excellent direction and support to our program. I also need to mention Jennifer Connolly, who is our Infection Prevention Coordinator. If it weren't for Jennifer's efforts in this endeavor, we would not have made the progress that we have made in our C. diff reduction program. So I want to acknowledge Jennifer's efforts. She's just been a tremendous support to our program in making this happen. So if we can go to the next slide. You can see this is a picture of St. Mary's, my home for about 30 years now. I've worked at St. Mary's. We're located in the high desert region of the Sierra Mountains. And just to give you a brief synopsis of what we do at St. Mary's, we're a 380-bed for-profit acute care and general medical and surgical hospital. We're owned and operated by Prime Healthcare Services. We were established by the Sisters of San Rafael early in this previous century. The hospital is over 100 years old, so has a tremendous legacy and history in our community. We have a network that includes outpatient, inpatient services, including home care and hospice services. We do in the Reno area, because of our visitors and the transient population and the casino community that we have in our area, we do have a very high-risk patient population, and this is in many different areas of medical practice. So it presents some challenges, and we've seen our demographics change over the last few years to a higher risk patient population. So next slide, please. Some objectives this morning. I want to be able to share information that will hopefully allow you to identify some potential barriers to proper identification of health facility onset C. diff cases. We've learned a lot in this area in just even the last 6-8 months. I want to be able to help you describe some strategies used to prevent C. difficile transmission, be an assist in initiating the development of a nurse-driven protocol for C. diff testing, to provide some additional guidance to physicians regarding appropriate testing for active disease, and to help everyone understand the importance, and I'm sure we all recognize this now, but this has become even more critical to our success in understanding the importance of a comprehensive and active antibiotic stewardship program. Next slide, please. Just to give you some history, we developed a very aggressive surveillance and testing program in 2015, and this was coming off of an experience at the end of 2014 where we actually had somewhat of an outbreak situation on one of our medical units for C. diff. We did a very comprehensive investigation and worked with the State of Nevada Bureau of Health to determine what could have been the causative issues In terms of the outbreak, we discovered after looking at all of these cases very closely that really nursing care was not implicated, neither was our environmental services protocols. They were all very well done and appropriate. What we did discover more than anything was an opportunity to work more with family members in terms of them following our isolation protocols and procedures, including good hand hygiene. But as a response, what we did was we cleaned the units aggressively. We did terminal cleaning, of all the area. We went to a facility-wide conversion to bleach products only, including our daily wipes. Hand hygiene was with soap and water only, and we have continued that practice anytime there's been any suggestion. And obviously, for any patient that's in what we call special contact precautions for C. diff or Nyer virus, the staff and the visitors are to use hand hygiene with soap and water only. We also instituted a new program using a product called Exolite, which is a terminal cleaning spray of all of our isolation rooms after the patients have left. And we are doing that consistently and have seen great progress and great results with that. We also do an ATP testing program through the 3M company. That happens to be the provider that we use for our adenosine triphosphate testing. This allows us to determine the effectiveness of our EVS program and how they are cleaning. We just recently added additional items to the list of those things that we're testing in each room as we are designated as high touch on different areas of the room. And on a monthly basis, I receive reports in the infection prevention department from our EVS department, which shows the effectiveness of their cleaning in all areas of the hospital. This has allowed the EVS staff also to receive direct feedback from their supervisors as to their cleaning practices, and this has been very, very successful in terms of our environmental cleaning and providing education to our staff to improve their practices. We also developed an aggressive screening program, and with this we saw a dramatic increase in the number of C. diff cases that we were identifying last year. And so we had to go back and basically at the end of this last year rethink about this strategy and determine whether or not we were possibly using PCR testing too much in the identification of these cases. So were we actually, and I know that a lot of people are still struggling with this nationwide, but in determining if we were truly seeing active C. diff disease or was it just a matter of colonization. So I will be touching on that a little bit later in this discussion. But what we did do at that time, because we found that through our infectious disease physicians, we were seeing false toxin negative tests as being a problem in the identification of disease. We went to an automatic process that with the enzyme testing, if we found an antigen positive and toxin negative finding and the patient was symptomatic, that we were automatically doing PCR testing, and that increased our rates significantly in 2015. So can we go to the next slide, please? So even though we had a nurse-driven testing protocol in place, in policy, what we determined was that it would probably be better for the nurses to put it into a more visual format. So at the end of last year, with the high rates that we were seeing, we actually put our algorithm together in an algorithm format. So it would be easy for the nurses to discern what they needed to do. On one side of the page, we put the nurse-driven protocol. On the flip side of our algorithm page, we put the physician algorithm, which allowed us to give the physicians a little bit more information as to what they should be doing for testing. So as you can see with this testing protocol, within 48 hours of upon admission or during hospital stay, if there was unformed stool that was discovered with a patient and that patient was not receiving laxatives or bowel prep for procedure, we were ordering the C. diff testing automatically through our nurse-driven protocol. What our biggest challenge was that we discovered last year was trying, not so much that these patients, the numbers that were going up were patients that were actually health facility onset, They became part of that definition because we were not capturing the testing of these patients within the first 3 days of admission. So when they fell on day 4, we were caught in a situation where we had to define them as health facility onset by the criteria, even though they may have been symptomatic early on in their stay. We were just not capturing that testing result when we needed to. So the nurses now, through the protocol, can have C. diff testing ordered, and we are using, as I mentioned, the EIA antigen toxin test for that. If the patient is antigen positive, toxin positive, there's no question. They are put in preemptive isolation as soon as C. diff disease is suspected, and we have now extended the isolation protocol so that any patient that tests positive for active disease is remaining in isolation for the duration of the hospital stay. Now, an exception to that might be if a patient, which happens occasionally, is in our intensive care unit, for example, and is going to be there for a very extended period of time, then certainly the protocol or precautions are open to negotiation, and the staff will work with the infection prevention department and our medical director to determine how long isolation needs to be in place for those long-term patients. If the patient is antigen positive and toxin negative, and it's within the first 3-day portion of their stay, we are still having automatic PCR testing done so that we can identify whether or not that patient has active disease quickly. The patient will remain isolated. Say the PCR comes back negative, the patient will remain isolated until they're asymptomatic, which means they will have formed stool. And in addition, the patient must have the ability to perform independently adequate personal hygiene and hand hygiene so that they are not posing any kind of transmission risk. Recognizing that once the patient is antigen positive, they need to be watched closely for any type of signs and symptoms that might be suggestive of active C. diff disease, and then they would be put in isolation again, and then testing would be redone. Obviously, if the patient's antigen negative, toxin negative, the patient will be removed from isolation at that point and will continue to monitor them for any other signs or symptoms of C. diff disease in the future in their hospitalization. Next slide, please. As part of our St. Mary's Regional Medical Physician algorithm, we wanted to assist our physicians in taking these just kind of one step further from the nursing protocol and giving them some direction in addition to what our staff was receiving. So as you can see, if you go to the antigen positive, toxin negative box, where we made our change that was new in this algorithm was what steps were to be taken if the patient were on day 4 or later. This is what I was talking about in terms of not doing the automatic PCR testing at this point. What we wanted to do is pull in clinical correlation and allow the physician and the staff at that time to determine whether or not PCR testing was actually required. Next slide, please. So this goes further as a continued drop down from that protocol. And so if they are antigen positive and toxin negative, we're asking the physician and the nursing staff to work together to consider those clinical correlations and additional risk. And you can see to the left and down those issues where we would consider it to be a high-risk situation. And this is where antibiotic stewardship really comes into play, obviously. But you can see the list of the antibiotics that are suspect and that we are looking at actively with our patients that are coming back as health facility onset cases. So these are our high-risk areas. And then if we are considering that the patient is high risk and that they are coming from a possible situation where there may be an outbreak situation or suspicion, then PCR testing will be ordered at that time. We have also given them some instructions over in the left-hand box that, as you can see, if the patient has been treated and is asymptomatic but develops symptoms 14 or more days after the original positive testing, we are recommended that they do repeat testing at that time to rule out a new onset of the C. difficile disease. So our next slide is a polling question, And I think more and more people are going to PCR testing, but I was just curious as to how many people out there are using PCR as the identification strategy for active C. diff disease. So, Lori, are you the one that handles the polling question?
Lisa's doing it, and she will
Okay.
give you a few more seconds for everyone to be able to answer, and then we'll end the polling.
Okay. Can you share that result with me, since obviously I can't see it?
Oh,
that
yes.
would be helpful.
Mm-hmm.
Thanks.
Okay, we're going to end the poll now. Okay. So if we're done with the poll.
Yeah, go ahead.
Okay. As far as the results.
So the results were yes, 41 people answered yes, 65%. 8% answered no, and 27% answered uncertain.
Oh, okay, great. Thanks.
Okay.
One of the challenges, with the PCR testing determination, and we ran into this and have had tremendous help with our Health Insight, representatives is, if you are using the PCR testing, please be sure that when you are entering your results into NHSN, that on a quarterly basis, when NHSN is polling you as to your methodology for testing, please be sure that you indicate that it's NAAT testing, so that your statistics will be stratified accordingly, because PCR obviously is more sensitive, so your rates are going to be showing higher than if you were just strictly using EIA or some other toxin type testing. So you want to be sure that when your SIRs are calculated, that you have an accurate comparison, because it can make your rates look very high, if you do not indicate your testing methodology appropriately for comparison. So I just wanted to add that little bit of advice, because Ellen, our capable and wonderful representative from Health Insight, has really helped us with that and navigating all of these issues with data entry and other things that we're dealing with. I want to mention on the next slide, so just a policy and protocol summary as it relates to our nursing protocols. One of the other things I wanted to mention that has really become an interesting component of our program is that as we move forward, with this protocol and tightening up our policies and procedures related to testing, we realized the importance that proton pump inhibitors has played as well in causing this type of disease. And so along with the antibiotic stewardship, we are really looking at our PPIs very closely. The patients that we are identifying now that we have resolved the issue of getting the testing done within the first 3 days, those that are falling out are not those cases that are showing any kind of indication of in-house transmission, but rather they are patients that are on these antibiotics or have been on PPIs for an extended period of time, and we are recognizing that we have a great opportunity to assist in educating not only our in-house physicians, but those in the community, that we need to be better stewards of all of these medications and in trying to prevent this disease. So in summary, we did a revision of our special contact precautions policy and protocol for nurse-driven C. diff testing, as I presented previously. We defined unformed stool as being any feces that conforms to the container. This is not just diarrhea, and we are referring our staff to the Bristol Stool Scale types 5, 6, or 7, which give very visual illustration of the type of stool that we are looking at. Form stool, this is another issue that we dealt with last year. The form stool was being sent for testing and was being tested, so we've tightened up that protocol. And so form stool is not sent for testing unless specifically requested by the physician. And our lab will automatically reject those stool samples, but we have requested, and they are working very closely with the floor, that if they do receive a form stool, that there is communication happening with the floor to make sure that was actually stool that needed to be tested or it was an error. Again, as I mentioned, patients receiving laxatives or bowel prep should not be tested unless there's other indications. We've had some challenges with the use of lactulose, and we have asked the staff not to dismiss testing just based solely on a patient being given lactulose. They need to look at a comprehensive assessment of the patient and talk to the physician to see if in fact there may be some indication for C. diff testing. So we are looking closely at those patients as well. Patient with a history of C. diff alone does not require isolation, and we've provided this education to our staff. He or she must be symptomatic, i.e. have, an unformed stool or other signs and symptoms of C. diff disease. As I mentioned, patient will be placed in special contact precautions immediately when C. diff is suspected. And per our protocols here at St. Mary's, physicians' orders are not required to place a patient in isolation. So this is part of our nurse-driven and just overall hospital protocol as it relates to transmission-based isolation protocols. A patient, as I mentioned before, with an active C. diff infection at any time during hospitalization will remain in isolation for the duration of his or her stay at St. Mary's. So as we go to the last slide, just in review, we really encourage those who haven't to build a comprehensive antibiotic stewardship program as we have here at St. Mary's. Our pharmacists are very engaged in this program with us. We also, per our performance improvement department direction, we now have a monthly HAI reduction meeting with staff and supervisors, excuse me. We actually have the first Wednesday of every month designated as our performance improvement day, and there is somewhere between 8 and 10 different committee meetings that occur on that day, and we all get together and we strategize and work on improvements related to various performance improvement initiatives in our hospital. And we've had great buy-in from the staff, and we have learned so much from them, and I really encourage you to engage them in this program as well. We've discovered some real surprises per the staff input about our ordering protocols, and so we have this is mushroomed into becoming much more than what we expected it to be, but we are taking advantage of opportunities to improve our systems to allow our staff to do their job and to identify these cases more readily. We've done a lot of staff education, obviously, but I think one of the biggest things that has been a factor in this improvement is our daily, and we call it affectionately, our poop report. And Jennifer is the one that has really spearheaded this, along with assistance from PI. Heather Schofield has really played a big part in this as manager of our performance improvement department. And so there's a report that is run every morning that outlines stool characteristics and testing status. And then Jennifer goes to each one of the floors and discusses those cases to ensure that we are identifying people rapidly and getting the testing done within the parameters that we need to. As I mentioned before, we did do some revisions of our EVS products, and just recently we went to a new bleach wipe protocol house-wide, which has shown through ATP testing to be even more effective than what we were doing before. So we have found excellent results with that as well. And just in final summary, after we instituted these protocols, and with January being the onset of our biggest push and drive towards this, we actually saw a 70% reduction in our health facility onset cases. So we are feeling very gratified, and we've continued to see that result through January, February, and now into March. So the next slide is for comments or questions, and thank you so much for your attention and the opportunity to share this program with you.
Thank you, Rochelle. So now it's time for questions. If you have questions, please, Azure, if you could open the phone lines up, or please chat them in. We have several questions on the chat. One question was from Jen Wright, and she was asking, is there a risk for those that are using different acid reflux treatments, such as apple cider vinegar daily?
Gosh, that I don't know. That's a really good question. I would have to, look into that further. But, I think that, and I'm sure some of our other experts can address this question much better than I could, but, the big issue with the PPIs is changing the pH and the whole environment, the gut environment. So I would be suspicious that anything that's going to change that pH or the environment of the gut, the intestinal tract, may present a risk for C. difficile disease. But I could not address those two specific things because I just don't know about those specifically.
Thank you.
Ladies and gentlemen, at this time, if you have a question, please press the number 1 key on your touch-tone telephone. Again, if you have a question, please press the number 1 key on your touch-tone telephone. There are no callers in queue for questions.
Thank you. Rochelle, there's another question in the chat, and it says, I thought there were 3 different negative stool samples had to be documented for patients to not be put in C. diff precautions on each subsequent admission, even if they're asymptomatic. So,
that is not part of our protocol, and I think protocols vary. But that is not something that we have looked at doing. We really look more for symptom onset. We don't want to implicate people with a history as necessarily being a transmission risk unless we have symptomology. So that's the protocol that we use. But I'd be interested in hearing more about that. If someone wants to contact me, with their protocol, we can certainly look at that.
great, thank you. And here's another question in chat. A person wanting to know what your staffing is for your infection control department.
We have 2 people in our infection prevention department. And I should have mentioned that even though that we are a 380-bed facility, our census runs anywhere from about 170 to a little over 200. So we have 2 FTEs that are in our infection prevention department.
Another question in chat is, do you have any data pre and post interventions?
Yes, I do, and that's what I alluded to, that we actually saw the 70% reduction in January. So yes, we do have data that has shown a significant, decrease in our HFO rate since we instituted these protocols.
Good. And there's one more question in chat. The writer says, our MD always starts acidophilus with treatment. Has this shown to be effective?
My understanding, we've had a lot of discussions, and our pharmacist that's on the panel, I'm sure, can maybe possibly add to this discussion as well. In speaking with our pharmacist, there is no evidence that they have seen or can share that shows that probiotics, are helpful, in terms of C. diff disease. But I'm sure that, that's an ongoing study, and more and more people are suggesting that might be something to help. But we just have not seen that evidence, nor can they provide me any scientific evidence to support that right now.
Great, thank you. We have another question in chat. Is the PCR test run in the first 1 to 3 days? How often should they be performed after that?
The PCR testing that we do on the antigen positive, toxin negative patients are automatically done within the first 3 days. If the patient is negative at that point, we do not recommend testing at least within 7 days. So we would push it out beyond 7 days, and then the patient would have to become symptomatic again. But PCR testing and the antigen testing is not something we do routinely or continually. It's a one-time thing.
Great, thank you. Here's another question. You use the term aggressive screening. Does this mean you are testing patients on admission who do not have symptoms?
No, we are. When I was speaking of aggressive screening, that was more as it related to the use of PCR testing.
And then, thank you. And then here's another question. I am brand new. What is PCR testing?
PCR testing is a genotesting that allows you to go to a finer molecular level, in determining the presence of C. diff. So it is just a more finely tuned laboratory testing that's available now, to help identify these cases. But unfortunately, it doesn't always determine, it will determine the presence of C. difficile, but it doesn't always help us determine if the patient has active disease. So that's why you have to be careful in the use of PCR testing, because you may be identifying cases that are colonized rather than truly active C. diff cases.
Great, thank you so much. I think we're about out of time. We have a few more questions, so we'll capture these questions and hopefully we'll be able to answer them towards the end. Thank you so much, Rochelle, for telling us of your strategies and all the hard work you've been doing at your hospital.
Great, thank you very much.
Thank you.